to go. Okay. Good evening, everyone. We do have a quorum, so we will now call our meeting to order. I will do our invocation, and then after that, we will move into our agenda items. Father, we just thank you for this day, oh God. Thank you for being with us. We ask your guidance as we go through this meeting to handle the business for Cabarrus County. In your name we pray, amen. I do want to make a notation that we are going to have amendment to the agenda, and what we are looking at doing is on the reports where it says COVID-19 update, we are going to move that down to our business agenda, and it will now be COVID-19 updates along with board resolution. So may I get a motion to adopt the amended agenda?
I move to adopt that.
Thank you, Cecilia. And may I get a second?
I second.
Okay, and thank you very much. That was Dr. Daylor.
Yep.
All in favor of Dr. Daylor?
Aye.
Dr. Higler?
Aye.
Cecilia Perez?
Aye.
Dr. Pons? Mark Spitzer?
Aye.
And myself, aye. Thank you very much. May I also have a motion to approve our minutes from our November 9th meeting? And we can maybe get that motion?
I make the motion to approve, Mr. Mack.
Thank you very much, Cecilia. And may I get a second?
Second. I
Thank
second,
you.
Dan Heckler.
Thank you very much, Mark. And all in favor, I'll go down the list again. Dr. Daylor? Dr. Kim Daylor? Dr. Hagler?
Aye.
Cecilia Perez?
Aye.
Dr. Pons?
Aye.
Mark Spitzer?
Aye.
And myself, James Mack. Thank you very much. At this time, we will have the installation of our new member, which is Miss Asha Rodriguez. She is the new board member that will be replacing Chris Bowe from Atrium Health. So may I get a motion to install Miss Rodriguez as our new board member? And then at that point, we will have her to take the oath.
I so move.
Okay, thank you very much, Mark. And may I get a second?
Second. Pons.
All right. And all in favor, Dr. Daylor,
Aye.
Dr. Hagler,
Aye.
Cecilia Perez,
Aye.
Dr. Pons,
Aye.
Mark Spitzer,
Aye.
and myself, James Mack. Thank you very much. And they will now administer the oath.
Oh, okay, Asha, I'm going to read the oath. You can repeat after me.
Yes.
I, Asha Rodriguez, do solemnly affirm
I, Asha Rodriguez, do solemnly affirm
that I will support and maintain
that I will support and maintain
the Constitution and laws of the United States
the Constitution and laws of the United States
and the Constitution and laws of North Carolina,
and the Constitution and laws of North Carolina,
not inconsistent therewith,
not inconsistent therewith,
and that I will faithfully discharge
and that I will faithfully discharge
my duties as a member of the Cabarrus County Health Authority Board of Commissioners. My duties as a member
my duties as a member
of the Cabarrus County Health Authority
as the Cabarrus, as a member of the Cabarrus County Health Authority
Board of Commissioners.
Board of Commissioners.
So help me God.
So help me God.
Okay.
Thank you very much.
Thank you and welcome.
Thank you.
And welcome to our board, Ms. Asha Rodriguez.
Thank you.
Before I make a motion as far as the board chairman. I also want to introduce, we do have our new board clerk online, Ms. Rakisha Franklin. And again, she would just wave and say hi to everyone. And we thank you for assuming your new responsibilities on the board as the board clerk.
Thank you
So,
for having me.
all of
Welcome.
the correspondence will be coming from her moving forward.
Yes.
Okay. Also, we would want to, I need a motion to, Dr. Pons, who was our vice chairman, will be assuming the chairman's role starting in our March meeting. And what I would like to have is a motion that Dr. Pons will be the chairman moving forward, because my last day will be January 31st, but that Dr. Pons will be serving as the board chairman with our March meeting. So may I get a motion?
So moved.
Thank you very much, Mark. And may I get a second?
I second.
Thank you very much, Cecilia. All in favor, Dr. Daylor,
Aye.
Dr. Hagler,
Aye.
Cecilia Perez,
Aye.
Dr. Pons,
Aye.
Asha Rodriguez,
Aye.
Mark Spitzer,
Aye.
and myself. Thank you very much.
And Mr. Mack, if I can just clarify there, that as the vice chair, Dr. Pons will be filling out the remainder of your term as chair, which would be through June. And then you would be holding nominations in June for the new fiscal year at that time, just for that clarity there.
All right, thank you very much. At this point, we will now go into our reports, and Sue Yates, you are up.
Yes, for the new folks on the board meeting, my name is Sue Yates, and I'm the finance director. I've been here since 2013, and the next three reports I share at each one of the board meetings, so you can see how we're doing as an organization and through our programs. This first report is our financial summary report, and it's through December 31st. The first column for FY22, the original budget, shows that we started the year off at $24 million. With all the additional funding we have received throughout the year, we are now up to $32 million, and that will continue to increase. You'll see in the budget revisions. So a big part of how we perform is based on a Medicaid cost settlement, since we have so many Medicaid patients. That is an estimate that we do based on past year's experience. So right now, it looks like we will end the year somewhere around $400,000. That does increase or has increased for us based on the additional funding, additional indirects, and increased billing through our COVID testing and our COVID vaccinations. In the Medicaid cost settlement, we hope to have that by the end of December, but the state is trying to figure out how to handle all the COVID vaccines and all the nurses' time and staff time around the COVID clinics. So we are currently still have that as an estimate and have provided as late as last week additional information to help pull that together for the end of the year. Does the board have any questions at this time on the finance report?
I guess, Sue, the argument is they already paid you for the, you
No.
got it from the feds on the nurses and the vaccinations.
So we do bill for the admin fee for that. Our test and the vaccines are free, so we don't bill for that, but we do have the vaccine administration charges that we're able to do. And we have a lot of Medicaid patients that when you add into the mix, all the additional Medicare funds that we're getting from the older population, getting the vaccine and other things, the The state just has not had that as part of the cost settlement in the past. So they're trying to make sure it's reflected correctly on the cost settlement report and in the right categories. So they're just asking for additional detail to get our ratios where they should be. So we have not received it yet. Once we give the state our information, they pull together the report, it comes back to us. Dr. Coyle signs the attestation letter. I'm sorry, I can't. My voice has been a little iffy lately, but she signs the letter, and that's our tentative settlement. We send it back, and then usually within 30 to 60 days, we receive the funds.
Okay, thanks.
Okay. The next is a quick snapshot of where we are at the end of December. I do have dental and clinical services, both a lighter green at this time. They're still performing well, especially with the Medicaid cost settlement number in there. But dental health, I just want to make the board aware, has not really been fully operational in the schools this year. And in the past before COVID, that was a whole team in dental. And then in clinical services, the state of North Carolina moved to managed care this year. And so working with the PHPs, trying to make sure our reimbursements are correct and the new process and procedures. So just going through there have been a couple of billing issues across the state, and the local health directors are working to help us all get that settled. And it is improving. It still just has a little ways to go.
Sue, before you move on to the next slide, I was talking to myself on mute on the earlier slide. I know that this is not a cash, the P&L is not a cash flow, but it certainly reflects a $303,000 deficit prior to the Medicaid reimbursement. The question that I have is there actually a deficit that we run at points? And if so, while we're waiting for Medicaid, if so, how do we cover that? Is the first question, and then I may have a follow-on.
Okay, so almost all of our funding is paid 1 month after our expenses happen. So every month, our expenses are higher than our revenues come in, because once we spend the money, we create reports for each funder and send payroll reports and invoices and those things to the funder. They verify that they're legitimate expenses. They send us the funds after that. As far as that deficit, if CHA did not receive the cost settlement, since we serve Medicaid patients, a lot of times they cost more to provide services to than Medicaid at the state level reimburses. So the Medicaid cost settlement is the federal portion to ensure Medicaid providers are trued up on their cost. So yes, it is likely if we did not get the federal share of that, then we would be running in a deficit as an organization, because we serve so many Medicaid patients in dental and our pediatric clinics.
And that's very helpful. I guess in part what I'm asking is, month over month, week over week, do we actually get to a place where we have negative cash, that we're in a position where we have to bring additional money out of our reserves in order to cover expenses before revenue comes in? That's the question that I'm interested in hearing about.
Okay, we have 3 cash accounts at Wells Fargo. One of them is a payroll account, and we only use it in and out for payroll. The other is our operating account, and we manage that account to ensure there's enough in there to cover our operating expenses. And the rest is invested in North Carolina Capital Management. And so the bulk of that cash is the revenues that are coming in from the year, plus our reserves. So our fund balance sits in those accounts. And so we put what we can invest into the capital management trust, anything that we need for our operating expenses. We do a transfer back and forth if our funds in our operating gets a little high and we want to push it back to the capital management account. So it's the fund balance that we have that covers our cash flow, since we are paid after our expenses happen. So we're fortunate that we have enough of a balance that we could go 3 months without being reimbursed without having a cash flow issue.
So in effect, is what you're saying, that we are borrowing from our fund balance or appropriating from our fund balance to cover cash flow shortages. I think that's what you're saying. And if that's the case, are we replenishing the fund balance with whatever money has been appropriated from it when the Medicare settlement comes in? And is that a
Yes.
fair question?
Whenever the Medicaid settlement comes in, if there's, anytime we have any additional funds, we put it back in the capital management account. And so that's how that works. So we do use those funds to make sure that our cash flow is working, because of the way that public health is funded. Our state agreement funds are all paid a month after expenses. All of our federal awards are paid a month after. Almost all of our grants are as well. We only have a handful of funds that are paid up front that we already have the funds, and then we do the expenses. But most of them are paid after. So yes, we do have to use our cash to ensure that we have adequate cash flow. But all of our funders are reputable, and we get them the documentation, and there's never really been an issue to get reimbursed from any of the organizations. And if they don't reimburse us when they're supposed to, we send an email and it gets resolved very quickly.
Thank you.
Mm-hmm. Okay. This third report is a variance report. It looks at last year over this year, and CHA is cash basis, as both Dr. Hagler and Mr. Spitzer indicated. So, but on this report, you can see how much more we're spending this year and receiving this year than we have in the past year. So our additional funding is increasing our budget at a rate that CHA has not seen in the past. We're typically anywhere from 23 to 26 million for our budget. So it's continuing to increase, and that is causing our month over month variances to be increased. Does the board have any questions about the variance report? Okay.
Okay, if there are no questions, then we will move to our next agenda item, which would be the dental scorecard, and that would be Dr. Steele.
If I could just jump in very quickly to introduce Dr. Steele. We've done a little bit of restructuring in the dental department, and Dr. Steele, who has been a staff dentist for a number of years with us, is assuming the role of dental director over the program. She will both be providing continued clinical care 50% of the time, and then administrative oversight of the program for the other 50% of the time. We're really excited to have Ellie lead the program. She has some great ideas and wonderful innovative thoughts for moving forward, and she has worked very hard on the dental report card to introduce value-based care and other efforts at outcomes-oriented measures. So we're excited to have her here tonight to share the dental report card, and again, welcome her into this new leadership role.
Well, thank you, Bonnie. It's nice to meet everyone. I'm Dr. Ellie Steele. I'm, again, the newly installed director, and I'm also a lifelong Cabarrus County resident. So I'm always interested in improving the health of this community from not just a provider standpoint, but from a citizen standpoint. So since Sue talked about all the fun budget stuff, what better place to start for the dental overview than our scorecards? Just a refresher, our dental scorecards and all the scorecards at CHA are going into our performance and population accountability. For dental, we have been very strongly affected by COVID. Same for the entire world, but also for dental, where we completely shut down except for very emergent treatment in 2020. So if we take a look at our data, there's going to be some areas where you're like, okay, where is this data coming from? I'm sorry, you might hear my cats. So we are going to be looking at both our performance accountability and population accountability. Luckily, if we take a look at the individual population accountability measures, our emergency room visits have actually remained very stable over a 3-year period. While we want that number to go down, that's a good thing that COVID hasn't caused us to have spikes from dental in our emergency rooms. The other 3 metrics in our population accountability were greatly affected from shutdowns related to COVID and continue to be affected today. So with this population accountability, I narrowed down to focus on 2 measures tonight. The first is kindergarten screenings. Kindergarten screenings are a tool that the state uses to identify areas of highest needs for dental services, as well as creating that data source to compare North Carolina to the rest of the country. We at Cabarrus Health Alliance use kindergarten screenings as a monitoring metric, but also to see which schools we need to get our mobile services into first. As you all know, our services were completely paused due to COVID. And so that affected our data for the end of the 2019-2020 school year, the entirety of the 2020-2021 school year, and it has been a slow start to get back into schools this year. As Sue mentioned, the mobile program is a big part of our dental program because we have staff that spend their entire time focused on it, as well as clinical staff that rotate through. As of right now, our community program is completely paused at schools for the month of January. Decision was made with the school's support as well as Bonnie's support because the COVID surge is just making it very stressful, if not impossible, to get out to reach the students that need it the most. We hope to resume screenings and comprehensive care in February, but of course, we're going to be monitoring the COVID data as well as being respectful of our teachers and schools' needs. So with that background, if we look at the kindergarten screening scorecards, we can see that it has been fairly stable with children in Cabarrus County with untreated decay ranging from about 12 to 15% for kindergartners. This is higher than Region 4's overall decay rate, which hovers around 11%. And unfortunately, there is no data for Cabarrus County in 2021 and only limited data so far for 2022 school year. However, of the 8 schools screened so far this year, they are averaging 10% more children having untreated decay present than the same schools in 2020. While more data is obviously needed to evaluate this trend, this supports the initial data coming in from across the country of COVID increasing decay rates for school-aged kids due to pauses in all dental treatment and the increased availability and frequency of carbohydrates consumption at home. COVID effects can also be seen on children with Medicaid receiving the preventive dental services, as seen in the bottom graph. As this data comes from NCDHHS, it is delayed, but this is a big concern for us because prevention is a huge focus of ours, and we want to see these numbers for Cabarrus County increase. Okay. If we go to our performance accountability, again, community dental program has really had this big expected drop in fiscal year 21 with no kindergarten screening data. And as we talked about with the kindergarten screenings, we are seeing this untreated decay rate kind of change a lot with this COVID delay, but also with provider changes, as well as this return to comprehensive care that took us about 6 months from the initial lockdown from COVID. We are also putting an emphasis on prevention and non-surgical caries management, which is changing again how we measure this. These two factors, the caries risk assessment and self-management goals, are key components of value-based care, which Dr. Coyle mentioned. Both the ADA, that's the American Dental Association, the Policy Institute, and their Dental Quality Alliance are looking at these indicators as value-based care and preventive measures. In North Carolina in 2018, only 0.2% of children have this documented caries risk assessment. So the good news for us is that we are being steady around 90% in that measurement, but we do want to make sure that we increase that to closer to 100%. We also have room for improvement in our self-management goals, with either setting and maintaining these self-management goals where we try to motivate our patients to make changes themselves. But this number is so low either to not motivating our patients not being in a place where dental care is something that they are focusing on, or we're just not documenting. That is something that we will be working on as a department over the next few months. For our next steps in dental, community dental, our community outreach program is so important, and we are going to be starting that back up, revamping it, and adjusting to all this COVID, and then of course our staffing difficulties in the schools. We are really aware that we should not be adding to the stress of our teachers, our educators, our nurses, all of the support staff, because it is such a stressful time. We are also working hard to de-aggregate data to identify turn the curve opportunities. We want to be able to look at this data and say, okay, we are doing a really good job of reaching this population. How can we reach everyone? I know that was a lot of information. So if anybody had any questions, I would be happy to answer them.
Hey, Dr. Steele. This is Dr.
Hi,
Dale.
Dr. Taylor.
Hello. So on the performance accountability on your chart, where you have percentage of patients with untreated tooth decay, but your discussion is mostly oriented towards children. So are we looking at other age groups? Are we keeping it to the school age population, or what is that distinction?
So this measure for our performance accountability for our patients, this is caries prevalence when they come in for their initial exam. So either periodic exam or comprehensive exam. So this is across the board for all of our patients. Of course, this is more skewed towards that school age population because our practice is skewed towards the school age population, with still averaging about 82% of our population less than 18 years old.
Okay. And
I can definitely get that broken down by age, though.
But when you were closing, you said that you are going to sort of separate things out. So that could be something that might be interesting particularly if we're going to say percentage of patients, then if we could separate that out. And then also, if they're coming in and it's all populations coming in, when you do the screenings for kindergartners, are you using the calibrated screening method of the North Carolina DHHS segment, the oral health section?
We are using guidelines by the oral health section of DHHS. Unfortunately, we have not been, monitoring, or we have not been recording race and ethnicity, partially because the screenings happen at school without parents reporting that data. So there are some data collection issues there to deaggregate it, but we are using the oral health section's guidelines.
But in terms of exactly how we determine whether caries or sealants are on children's teeth, that's through a visual screening. Is that correct out in the community? Or is that still the way that that's done, or has that changed?
It is still a visual screening, and it is done by one of our public health hygienists.
So in the clinic where you have the second one, which is the performance accountability, are the providers, the dentists, I'm assuming it's dentists that are making those diagnoses? Maybe not, but are they standardized in their assessment, and is it using radiographic and clinical, or how is that? Is that calibrated? Or if you're going to be trying to follow people, then are we all doing the same thing?
That's a great question, Dr. Naylor. We have not done too many calibration exercises with our current group of providers. We have done calibration exercises in the past using radiographs, and that is a definite data, a potential source of error. So we will definitely follow up on that and add that to our list of provider calibration.
Okay. And then finally, with the self-management goals, would that be something that would be looked at with other disciplines across CHA, since it seems to me that with this difficult time and changes in caregiver status and changes in school support and overall access, that everybody would probably, that's getting any kind of home instruction, everybody might be struggling across a variety of disciplines. So that might be just another way to look at, it's not just motivating patients or not just documenting it. It just could be so many determinants of health that are impacted. And so you might be able to share that, that exercise with other folks, maybe, I don't know, but it just seems like there's a lot going on in that one little report of goals. So
there is, and that's one of the hard parts with self-management goals and value-based care, is that our metrics don't always represent how much effort we're putting into it. Sure. And why we do need to collaborate with other departments. We do have a meeting set up with WIC next week to talk about self-management goals, because we have a very high overlap in our patients. So that's our departments that we will be working with on those goals.
Well, great. And congratulations. I know this was a lot that you walked in on. I really do know that. For you to walk in and have to manage these reports when you haven't had hands-on, I really know that that can be a challenge. So there you go. You've done great. Thank you.
Any other questions? If not, again, thank you very much for your scorecard update, Dr. Steele. And again, congratulations on your new role and your new responsibilities.
Thank you.
All right. Our next agenda item will be the Health Director's Report.
Yes. In the interest of time, since we have a number of other very important issues to get to this evening, I am going to give a very, very abbreviated report, limited to simply saying this. This past year with COVID has probably been one of the most challenging years for CHA, and the past few months even more challenging, as we've seen numbers increasing more than ever, and as a result, the need for expanded programs and services. And yet, despite these challenges, this agency, the staff have risen to the occasion every single time things have gotten even just a little bit more complicated. So I do want to thank all of our program areas, from our support services through our direct services to our clinical services and administrative support, that everyone has just really stepped up to make sure that we are protecting the residents in our county. I encourage you all to look through my report more directly, and if you have any questions, please reach out to me after the meeting or sometime this week so that I can provide any clarification. But been working hard, securing a lot of grants, getting people hired for those grants, and all of the support services that they need so that we can focus not just on COVID, but on community engagement and resiliency in general. So a big, again, shout out to the staff here for stepping up during very challenging times.
Okay. Thank you very much, Dr. Coyle. And with that being said, we will move to our consent agenda items, and that will be Sue Yates will be up next.
So on the consent agenda items, you have our budget revisions. On this budget revisions, there are 14 that for the board, we received a new COSAP grant for behavioral health from the Department of Justice. We have received a public health regional workforce agreement addenda for an initiative around COVID and being approached in a regional way. We have received funds from HRSA and the Provider Relief Fund Phase 4. And there's a viral hepatitis prevention grant for $36,000. And I also, number 14 does have $0. I wanted to bring this to the board. We are wanting to create a new department for behavioral health and pull it out from clinical services, as it is a new area that we are looking to grow and want to make sure that we can pull those out and kind of show that separately than our regular clinical services. Does the board have any questions?
Okay, if there are no questions, may I get a motion to accept the budget revisions?
Motion to accept.
Thank you very much, Dr. Daly. May I get a second?
Second.
Thank you very much, Mark. All in favor, Dr. Daly?
Aye.
Dr. Hagler?
Aye.
Cecilia Perez?
Aye.
Dr. Pons?
Aye.
Asha Rodriguez?
Aye.
Mark Spitzer?
Aye.
And myself, James Mack. Thank you very much. Aye. Our next item would be our business agenda, and I'm going to ask Dr. Pons, since she was on the nominating committee, runs the nominating committee, as far as the board membership, if she would basically update us where we are at the present time, and then we will basically go forward with motions from there.
Yes, the board membership, of course, Mr. Mack is stepping down, and so we have to replace him with a community member on the board. We had the nominating committee had a discussion about this, and we also had a meeting with a prospective board member. In this extraordinary time and with all the things going on, we felt like experience with this board would be very well accepted and needed. And so we had reached out to Dr. Chip Buckwell, who originally was on our board last year when he stepped down from Cabarrus, from Kannapolis City Schools. He stepped down from our board. And so we're asking, we have reached out to him to ask his interest in becoming a community representative to the board. And he did express that he would be interested and would be happy to serve in that role. So it is the recommendation of the nominating committee that we ask Dr. Chip Buckwell to join our board as a community representative.
And he would be filling out the rest of my term, correct?
Yes, yes.
Okay. All right. May we get a motion to basically nominate Dr. Chip Buckwell as the representative for the board for the board in the community position, and he will be filling out the rest of my term. May we get a motion?
Yes, I would submit a motion to nominate Dr. Buckwell.
Okay, thank you very much, Dr. Daly. May we get a second?
I'll second that. If we let him know that he cannot give Daryl assignments.
Thank you very much, Mark, for your second and your additional comments. All in favor, Dr. Daly?
Aye.
Dr. Hagler?
Aye.
Cecilia Perez?
Aye.
Dr. Pons?
Aye.
Asha Rodriguez?
Aye.
Mark Spitzer?
Aye.
And myself. Thank you very much. And at the March meeting, since we do not have since our vice chairman is moving up to the board's chairman position, so I had made a discussion with Dr. Coyle that at the March meeting, at that point in time, when we will have a full slate of board members, then at that point in time, we could discuss and look at recommendations and also nominating someone for the vice chairman position.
Mm-hmm.
Are there any questions in reference to that? Okay, thank you very much. And our next item would be the COVID update, as well as the board resolutions that will be coming up from Dr. Coyle and also Aaron Shue.
All right. Good evening, everyone. Happy New Year. I hope everyone had a lovely holiday. So I'm going to split this presentation with Dr. Coyle, so I will get us started. As always, I like when I have the opportunity to bring you good news, but tonight is not one of those nights, unfortunately, but we will move through this quickly. So this slide is no stranger to you. This shows our case data. It's really important that we look at trends. And we hope, if anything, we've taught our community to look at trends, not just a point in time through this pandemic. But what I've circled here are our new cases in the past week. So that's 7 days, along with our updated death numbers. And you can see new cases in the past week, over 3,000. That's really just unprecedented for Cabarrus County. If you look at that December 13th date, we were at 536. So just really incredible surge with this variant. You can also see we've eclipsed the 400 number in terms of deaths. And so we can't imagine what these families are facing. We can't imagine what our healthcare partners are going through, and hospitals and long-term care facilities and hospice facilities. So just really gut-wrenching to see that number continue to climb. I'd like to point out that our percent positivity report came in just this afternoon, and it's at 35.7, yet another record-breaking number. A sliver of good news, if you want to look at it that way, we have seen a small dip in our number of Cabarrus residents hospitalized and total hospitalizations. So again, that 120 number sure does still put a large strain on our healthcare friends in our local hospital. It took us several weeks, but we finally ticked from 56 to 57% of the total population with at least one dose of vaccine. So still working to get people to become vaccinated. So this is just one of the ways we like to showcase the epi curve of this virus in our community. We like this because it's broken down and color coded by age bands. So you can see here just a dramatic increase. Now, this is the report that came in just today. So a small decrease, but you can see which age bands showed a decrease versus which stayed pretty stable or even small increases. And we're really focused on our school age population right now. And so you can see that they had a minor uptick from last week to this week. Our epidemiologist Medji also does a great job in looking at our 0 to 18 cases. So here you can see in our yellow, our 0 to 4-year-olds. And certainly if you've followed the news, our child care providers are trying to stay open for our working parents. But I tell you, it's becoming increasingly more difficult for them as well. So our 0 to 4-year-olds are not immune to this, and you can see their increase. Purple is the 5 to 11, gray is 12 to 17, and then our 18-year-olds we teased out because some of our 18-year-olds are graduated and in the workforce or on to college. Again, just graphically, you can see here the percent positive, but what I want to show is we've heard a lot also in the news about testing availability, or rather lack of testing availability. So what I'd like to show you and talk with you about is we've worked really hard with StarMed over the past couple of weeks to increase capacity. And so Marcella's on the call. I don't know if Amy's on the call, but I wanted to tell them a very public thank you for working with them and mobilizing quickly. StarMed has been working in Kannapolis behind Nova Credit Union for months now, and that parking lot has been sufficient. But when this surge started, the traffic just spilled over into Highway 3 down into the downtown area. And so we worked with City of Kannapolis officials and moved the StarMed location to the old Intimidators ballpark parking lot, which we know is just over the Rowan County line, but we're thankful for that availability. StarMed is also working with our partners at Charlotte Motor Speedway. Greg Walter and his team are just phenomenal, have rarely said no, but just give us a minute and we'll figure it out and get back to you. And so they are also have a location now at the ZMAX drag strip. And so we're hoping that these two locations, both larger and then with increased staffing capacity, will help. Additionally, True Care Pharmacy reached out and said, we'd like to help. We think we've got capacity. And so they are working out of the Cabarrus Arena. So again, our county partners have just been incredible using our drive-through plan. So True Care, they are doing mostly Mondays and Tuesdays due to the weather yesterday. They didn't do yesterday, so this week it's Tuesday and Wednesday, but they're at the Cabarrus Arena. So we're just really thankful for folks who are stepping up during this time, and we hope that this further alleviates capacity issues. So, and then the link at the bottom is the statewide testing locator. It's the link that I like to provide to people because it's more than just Cabarrus County, so you can look at other counties as well. Just quickly, cases per 100,000. Again, we're at over 3,000 per 100,000, but I think a better number you want to look at is the total cases in the last 14 days. And when we talk about the number of active cases, this is what we look at. So 6,600 active cases in Cabarrus County. That should stop all of us in our tracks. We really have not seen that number up to this point, because the entire state, you can see the entire state, I like to look at this one, is turning into that Duke blue color. The state has come out and said, we know that local health departments and schools and others cannot continue to do work as we've always done it. And so they have prioritized case investigation and contact tracing. So you can see here, I've just given you the first two tiers, but priority one are cases that are reported to be linked to a cluster or an outbreak. So if those are known to us and we learn of cases attached to them, then they automatically are investigated and traced. And then priority two includes several additional groups. So those in healthcare settings, congregate settings, so homeless shelters or congregate living shelters, K-12 schools, critical infrastructure, which would include food plants, our first responders, but then also community settings or events with large numbers of folks. So, and we would focus on our indoor events versus outdoor if we had to choose. And so I really wanted to show this to you to know that, if everyone in this community expects a call from someone to investigate their case at this point in time, that's not going to happen. It's not going to happen really anywhere in the United States, to be really honest with you. So individuals are being prioritized, cases are being prioritized, and that's why this community messaging of what to do if you're symptomatic or have a positive case is so important. And we just really appreciate the board working with us to get those messages out month over month. So just really quickly, again, we ticked up from 56 to 57% in terms of vaccinations. You can see where we stand here in our region of counties, but then also Marcella does a great job with keeping our thermometers updated. So on the left are our percentage of 5 and older vaccinated in the county, and then all population on the right. Because we have been talking about vaccinations so much with our 5 to 11-year-olds, because they're the newest group that's been eligible. This has been a really interesting table to watch grow. And so it's nice to see that, you know, just in the span of about 11 days, we ticked up 2 percentage points with our percentage of 5 to 11-year-olds becoming vaccinated. So again, continue to work with our partners on holding those events when we can. So wanted to talk just really quickly about how COVID is impacting CHA. So it absolutely is, and we want to be very transparent about that because we think that's important for you and the community to understand. So our employee health department or employee health nurse has been in contact with 73 employees since the beginning of 2022. The breakdown of those are 25 confirmed positives, 28 close contacts, and 20 symptomatic individuals who maybe didn't have a known exposure. Departments currently impacted are dental, our COVID department, school health, clinical services, and general admin. The one piece that we thought was really important and continues to drive home where we feel like vaccinations are working are of our unvaccinated employees, 34 of those have tested positive between December 10th and January 17th. So 10 out of 29 individuals who are unvaccinated have tested positive. And so I feel like Dr. Coyle wants to jump in here, so I'm going to pause.
No, I was just going to use 34% of our unvaccinated. You clarified it then after.
Sorry.
Yeah.
All right. So here our employee health nurse has done a really nice job graphically showing our vaccine status of our permanent employees. So here you can see 52 not only have their initial dose or first 2 doses of their vaccine, but are also boosted. We have another 19% that are vaccinated, but they're not quite eligible for their booster. We have another 19% that are vaccinated and they're overdue for their booster. And Lynn is really trying to work with them to get those boosters done. And then we have 10% that are partially vaccinated or unvaccinated. And then vaccination status of positive cases among our employees. So 20% of the positive cases were boosted, 20% were vaccinated but not yet eligible for the booster. So that 40% on the right. And then on the left, you've got another 30% that were partially or unvaccinated, or another 30% that were vaccinated but overdue for booster. So you can see, 60% are either partially vaccinated, unvaccinated, or they're lacking that booster. And certainly is what we're seeing in the community. When you look at statewide trends, you're seeing things very similar to how our realities are here at CHA.
Go ahead. You finish up with the vaccines, and then I just want to talk about them.
Okay. And then also Lynn Goley, our employee health nurse, does a great job of trying to identify, where have our staff been exposed? Because certainly we want to be a safe workplace. And if there's any peril there, we want to address it. So for us, 42% have had a high-risk family or household contact, and that's certainly what we're also seeing in the community. Households who have a positive, it tends to snowball to other family members. A high-risk community contact, meaning perhaps no masks while out to dinner or together. 8% a potential work contact, and then 43% really could not identify an exposure. And that's also what we hear a lot in the community, like, we're careful, we wear our mask when we're out and about, we haven't been around anybody we know. And so, they're just not sure. Dr. Coyle, did you want to jump in here?
Are you done with all of the vaccine slides? Yeah.
Yes.
I think what we really want the board to be thinking about, and we'll be informing you more as we gather information, is what we are going to define being fully vaccinated as amongst our employees. Because when we passed our requirement that all staff be vaccinated at CHA, that involved the 2-shot primary series. Now we have to think about whether we're including booster in that. We have been seeking clarification from the state and CDC about how do we define a fully vaccinated individual now? And they're indicating verbally that it includes having a booster shot, but they have not come out fully in writing yet that we have seen with that recommendation that fully vaccinated means that they're using the term up to date. So we'll talk also. I see Pat Kelly's on the call right now. We want to talk with him about whether or not we need to modify our policy so that it accounts for changes in vaccine boosters and schedules around COVID, so that we don't have to keep modifying our policy. So we, as of right now, as you saw, while 90% of our employees are vaccinated with the primary series, only about 52% have had the booster dose. So we really have to evaluate if we are now going to define fully vaccinated as including that booster dose and require the approximately 38% who still need their booster dose to get that at the appropriate time. So just informing you now that we're taking a look at that and defining whether or not booster doses is included in our definition of fully vaccinated. I am inclined to lean towards saying that it does. That is what we're talking about right now, but we're gathering more information, both from the public health perspective and the legal perspective around that recommendation. So likely be bringing that back in March to discuss further. Anybody have any thoughts or comments at this point about that particular issue? Okay, then the next part of this presentation and why we have moved the COVID update to the business agenda is because of, as you just saw in the data that Aaron has presented, again, unprecedented surging in our county as related to this newest variant has us thinking through what steps we should be taking from a public health perspective. So you can go ahead and advance that. We have been working very closely with our school districts, in particular, particularly the Cabarrus County School District, around what guidance we are recommending to them. And just to share some of the timeline updates here. We started seeing the surge back during the holiday break and started to be a little concerned about what would happen when students returned after the break, since we were already starting to see a surge from Omicron. On January 3rd, the Cabarrus County School Board of Education met and asked us to come and present metrics and answer questions they had. At that point, we recommended, and you can see on the right-hand side of the slide, what we were recommending to them on January 3rd, back when our positivity rate had increased to 15%, that we asked them to require masks at least through the end of January while we got through the surge, because they are still mask optional. Kannapolis School District is still in mask required status. And then if they kept masks as optional, that we would need to pause the Test to Stay program pilot that we were engaged in until our metrics returned from red, or so greater than 10% positivity and greater than 750 cases per 2-week period, due to the potential for additional spread and the lack of tests availability for the high numbers of students who would need testing, and also human resources in terms of our school nurses who would not be able to keep up with the capacity. That night on January 3rd, the Board of Education did remain mask optional. But we did pause the pilot that we were engaged in. And that, just for those of you who may not be aware, the pilot is, so the State Department of Health has contracted with the Duke ABC Collaborative to first evaluate the safety in mask required school districts for having children who are close contacts but remain asymptomatic, to have them be allowed to stay in school with tests on day 1, 3, 5, and 7, as long as those tests stay negative and they stay without symptoms. That analysis was done, that study was done in September, October, and November timeframe, and analyzed, and the data was presented over the holidays that showed that it did not in general result in much additional increase in transmission, just a slight little tick up, but not very much at all. So they felt that that was safe. There was then a second phase that the state, that the Duke Collaborative engaged in, to look at, can you, in a mask optional school district, can you take close contacts, and can you keep them in school if they are asymptomatic and they test negative on day 1, 3, 5, and 7? When that protocol first started, we were way back in orange criteria. We were not surging the way we are now. At that time, we agreed to participate in the project in order to keep kids in school, but we were very clear that if the spread continued, it got higher, if our transmission rates went higher, if our positivity rate went higher, that we would need to revisit participating in that, 1, for public health safety, and 2, for available resources. We just simply don't have enough staff for the hundreds and hundreds and hundreds of tests that would need to be conducted if cases continue to go up and up. So when we came back and we saw how much transmission had increased, we said we needed to pause our pilot, and we did that then on the 3rd. Then the state came out with new toolkit updates in which they limited the amount of time you need to quarantine and isolate if you are a close contact or a positive case, and also then extended the test to stay protocol in the toolkit for mask required schools. So if everyone was in masks in a school, close contacts who remained asymptomatic could stay in school and receive testing in a more limited capacity. So on the 10th, the Cabarrus County School Board of Education voted to go to a mask required policy for 14 days. Then we are now at the point where the school district may need to, that the school district may vote next week that they extended the mask required to next Monday. We are concerned because of our high rates of transmission that if schools are in a mask optional setting, that it would not be safe until we see the data that might come out. It would not be safe in a mask optional setting to pick back up with test to stay. Not only would it not be safe because of our high transmission and positivity rate, but we don't have the resources in terms of the amount of nurses and support staff to, again, conduct all those tests. So, a lot has been happening this past few weeks with the surge and with changes in toolkits and isolation and quarantine guidance. And so we are encouraging conversations and discussions with the Cabarrus County schools to work with us as they are making decisions about masks and or recommendations for the test to stay pilot. So we issued a memo to all schools in the school district asking them to please consider returning to a mask required environment during the surge if they are not already in that, and would like to propose a resolution tonight for the Board of Health to adopt to lend additional support to our recommendations. And it's two-part. And so the resolution would be that we would both recommend that all schools go into a mask required environment, and then that we not support tests to stay in mask optional settings until our metrics return down to till we get out of the red zone, so that positivity rate drops back to around the 10% range and our cases get down under 1,000. So here are a number of reasons why we think that's so important that we not do the test to stay pilot in a mask optional setting. Much of it relating to what Erin has just reviewed with you with our current state. Because the data has demonstrated that in mask required settings, following the toolkit test to stay options could be acceptable. We would still support that, but that due to the extreme spread right now, we would not support test to stay in a mask optional setting. So I think that was the last slide, Erin. Oh, I'm sorry. And so this chart helps summarize for you what I've just said verbally, that we would recommend that we could resume test to stay if the test to stay pilot if masks are optional once we get into that orange zone, which would require a positivity rate of less than 10%. Remember, we're now at 35.7%. So again, a level that's twice as high as anything we've seen before, and that our cases get down to that to under 728. I have suggested when Cabarrus County Schools requested written recommendations about what we might support, that we would at least start to work with, we would be very open to conversations and considerations about how to move forward with a test to stay pilot once we get down to 15% positivity and at least 1,000 cases. If we're seeing dramatic reductions, then we might kick in a little sooner than if we get all the way down to that 10% and 728 cases. So I know that was a lot of information. This is another chart that helps summarize the differences in the various tests to stay protocols. There's both the test to stay research protocol and then the strong schools state toolkit. And what we are saying is in a universal masking setting, because the state is supporting then a test to stay approach, we would support it. But until we get out of that red zone, supporting the research protocol really puts a lot more children at risk of becoming infected and then spreading to other family members and through the community. So what you see there down in the blue boxes is that the research protocol requires local health director approval. The Strong Schools Toolkit does not, because it's the state policy. So we would like to, we have already made the recommendation as the health director that we would not support the test to stay research protocol right now, but would like to again have the board consider adopting and approving a resolution that further supports that. This is the toolkit link in case you want to reference that as we move forward. So right now, you know, we really feel that we need to be using what are called layered mitigation strategies. No one strategy is going to completely control this pandemic, but when we layer them, when we have as many people vaccinated as possible, when we are using social distancing whenever possible, and when we are masking, we are more likely to help prevent the continued widespread transmission of the disease and help with hospitalizations and deaths in the long run. So we know that masks are not perfect and that they are not all equal, but that any barrier protection is better than nothing. So with that, I think we could pull up the resolution. This is in very, very draft form. We have just been compiling it today, but what we would essentially be looking for is the board to discuss if they think it would be appropriate to pass the resolution recommending that schools stay in a mask required setting while our transmission rates are so high. And then secondly, that we do not support, as a health department, we do not support test to stay again until our metrics return to a better level and until we are out of that red zone that we just showed you. So what questions do you have regarding this resolution, and what do you think about potentially proposing and adopting that?
Can you scroll the resolution? Yeah, thanks.
Has everyone had the opportunity to review it? And are there questions?
And there are a number of typos in here. So if there are specific things that you see and want to point out, certainly please don't feel like you should not do that.
Staff, students, visitors, pause, test to stay.
Just a point of clarification, either Bonnie or Aaron. 10% and the 728, how do those two interact with each other? Why both?
The positivity rate is telling you what percentage of people going for tests are testing positive. that is one metric that tells you how widespread your transmission may be. But then the total number of cases is also important, again, as just another measure. So they're really two metrics that are helping see how problematic your county is right now from two slightly different perspectives.
Metrics are less than, okay, or less than.
These have been the criteria
Yeah.
that the state has been highlighting as the most important metrics. Like the other metrics that are also considered very important are what's happening with your hospitalizations, how challenged are your hospitals, because ultimately that's a big concern. You know, we can't overwhelm our hospitals to the point where they cannot take care of not just COVID patients, but all patients. So that is another important metric, but we think these two really represent what's going on with total spread in the county.
In the body of this, did we reference how it overloads our resources in the community? Can you remind me? Yeah.
I do not believe we have a whereas statement that talks about the workforce. We talk about the transmissibility, but we do not talk about workforce. So if that is a desire of the board, we can certainly add that.
It just seems like that's something that people can relate to.
Important to include.
If not, is the board ready to basically make a motion to accept the resolution?
I make a motion to accept.
Okay, and that was Dr. Daylor. May I get a second?
I second.
That was Cecilia Perez. All in favor? Dr. Daylor?
Aye.
Dr. Hagler?
Aye.
Cecilia Perez?
Aye.
Dr. Pons?
Aye.
Asher Rodriguez?
Aye.
Mark Spitzer?
Aye.
And myself, James Mack. Aye. Thank you very much.
We will clean up any remaining typos that we find here, and we will expand upon Dr. Daylor's recommendation with impact on workforce, and we will get this to you as soon as possible.
Thank you very much, Aaron and Dr. Coyle. Our next agenda item would be informal public comments. And again, we will open the floor. I guess if there's anyone that is watching that would have any comments, we will open the floor at this point in time. Okay, if not, we would close the floor and move to our next agenda item, which would be announcements.
Yes. So as you all know, we've mentioned tonight once or twice that this is Mr. Mack's last meeting with us as a member of our board and as the chair of our board. And he has given us 10 very committed years of service. And we want to take this opportunity to extend a very, very special thanks to Mr. Mack for all that he has done in providing guidance and leadership for the full 10 years, but especially during these past 2 years as we've been working our way through the COVID pandemic. And we have a special award to present to him tonight. I'm hoping you can all see it on the screen. I'm going to read it to you. It says, the Public Health Authority of Cabarrus County Board of Health, James T. Mack Jr., in special recognition and appreciation for your outstanding performance and dedication to public health. You have made a difference, 2012 to 2022. And I know I'm speaking on behalf of the board when I say that it has been an absolute pleasure and an honor to work with you. And we thank you for the leadership that you have provided to CHA and to this board for so many years.
And thank you very much for the recommendation and also for the award. It has really been a pleasure to work with CHA, the leadership, as well as the associates and the community in my stay here. And again, wish I could continue on, but some other things as far as the passions have called me to re-engage in those things. And again, I appreciate just working with you guys. And like I said, again, I know you guys are set up to move forward. And again, everything looks good as far as new board members. So thank you guys very much for the job that you will continue to do for the community.
And you will probably all remember that our intention was to have a much more special celebration with Mr. Mack at our employee appreciation luncheon that was supposed to be in the end of December. We turned that into a just come and get your boxed lunch and then go sit somewhere with it, so that we did not have a lot of exposure as we were starting to see a surge. And then we were also hoping then to honor him at our years of dedicated service session that we would normally hold in January. But because we continue to surge, we're going to have to postpone that for a little while. So Mr. Mack, we do hope when we finally get to have our years of dedication that you will come back and allow us to honor you in a more appropriate manner with our thanks.
I certainly will. And again, thank you guys very much for all that you have done. Okay. We will now look at moving into our closed session. So if I could get a motion to enter into closed session.
I propose a motion to enter into closed session pursuant to North Carolina General Statute 143-318.11A1 to prevent the disclosure of information that's privileged or confidential pursuant to North Carolina law.
May I get a second?
I second.
Okay, all in favor, Dr. Daylor?
Aye.
Dr. Hagler?
Aye.
Cecilia Perez?
Aye.
Dr. Pons?
Aye.
Asha Rodriguez?
Aye.
Mark Spitzer?
Aye.
And James Mack. Thank you. I also. So again, at this point, we will now enter into our closed session.
We're here for you.
How much?
All right. Want to thank everyone for their participation in the board meeting tonight. And again, thank you so much for allowing me to serve as your board chairman for the last 9.5 years. At this point, may I have a motion to adjourn our meeting?
Motion to adjourn.
Thank you very much, Dr. Daylor. May I have a second?
I second.
Thank you very much, Cecilia. All in favor, Dr. Daylor,
Aye.
Dr. Hagler,
Aye.
Cecilia Perez,
Aye.
Dr. Pons,
Aye.
Asha Rodriguez,
Aye.
Mark Spitzer,
Yep.
and me. Thank you very much. We are now adjourned. You guys have a great evening.